Your role as MHPSS manager is to ensure that certain approaches and actions are taken that promote community-based support for people with severe mental disorders. These follow 8 steps. Meet lived realities at the community level through participatory, culturally relevant assessments, map and build on existing community-based knowledge and resources, include people with severe mental disorders and their families and caregivers in planning and implementation, establish community-driven referrals and follow-up, inform the wider population about the availability of services, cover the full spectrum of MHPSS need, actively involve community members in interventions, promote recovery at the community level. We know it is crucial to continually actively involve people with severe mental disorders and their families and caregivers in designing and modifying interventions and programs. This should be across the project cycle through mechanisms for dialogue, such as local program committees. These steps help make sure that program activities are feasible, socially and culturally appropriate, and acceptable, that they meet lived experiences of having a mental disorder, and that they build upon rather than undermine existing knowledge and resources. For more on steps 1, 2, and 3, you can refer to Module 10, Engaging with Communities. People with severe mental disorders may find it difficult to come for treatment or may drop out due to fear, stigma, neglect, poor access, or because services are socially and culturally inappropriate. Step 4 is community-driven referrals and follow-up, which may involve community personnel such as resource persons, traditional, hybrid, and faith-based healers, and other influential people. Programs may establish more formal referral and follow-up mechanisms that act as an extension of the facility. For example, health workers or volunteers providing home visits. Two-way referral pathways mean community to facility, but also facility to community, and may include working with traditional and faith-based healing systems. Families, peers, and the wider community are also crucial points of referral and are necessary for effective follow-up. The IOM-PMT model should have, where possible, referral teams. These teams may include a psychiatric nurse, a social worker, and driver or similar professionals. Usually, they would be sourced from the affected communities and so can act as community catalysts for referral. They may also include translators or cultural mediators. Step 5 is to inform the wider population about the content and availability of services. Community resource personnel should be involved as they are more likely to be trusted. In IOM PMTs, the referral team can organize information workshops on existing mental health services. They should make sure that clear information is always visible at MHPSS hubs. When sensitizing communities about services, supply must meet demand to avoid frustration and inconsistent access to treatment. This requires close communication between community-based actors and the service providers. In humanitarian settings, people with severe mental disorders are often confronted with extra challenges to their daily routine and self-care. Step 6 is to cover the full spectrum of MHPSS needs, which means all layers of the IASC intervention pyramid. Special considerations are likely necessary for access to socially and culturally appropriate basic services and security, Layer 1, and appropriate community and family supports, Layer 2. This might include advising people about availability of basic services and security, giving information on basic self-care, referral, and collaboration with social services, and inclusion in mainstream programming. IOM PMTs can support this process through social work-oriented case management, referral to other recreational socialization and artistic activities organized by PMTs, and providing a continuum of care when making these links. Step 7 is to actively involve community members in interventions. There are a number of community-based intervention models for people with severe mental disorders, which involve members of the community and are appropriate for use in emergency settings. These include peer support, caregiver interventions, and multifamily psychoeducation groups. The final step to promoting community-based care for people with severe mental disorders, Step 8, is to promote recovery at the community level. The meaning of recovery from mental disorder can mean different things to different people. You may have supported people who feel that maintaining a steady state with their mental health is a type of recovery in itself. For many, it is not about being cured, but about regaining control of their identity in life, having hope in their life, and living a life that has a meaning for them, whether that be through work, relationships, community engagement, or some or all of these. Key components of recovery can include relationships, inclusion in opportunities, meaning and purpose, dreams and aspirations, control and choice, managing ups and downs, and positive risk-taking. Activities that promote recovery may be most effective when delivered at the community level. We will now go through 2 examples. Different types of interventions that enhance vocational and economic inclusion are often labelled as recovery-oriented. Livelihood interventions have also benefited people living with mental disorders. People experiencing severe problems with their mental health may be at higher risk of experiencing homelessness and house instability. Independent living and supported housing can act as a base from which people can achieve numerous recovery goals. Of course, this might look very different in different settings, and the WHO advises that such interventions are culturally and contextually appropriate. Consider local resources and local cultural norms, and involve people, their families, caregivers, and wider community in their design and implementation. People with severe mental disorders may be at high risk of human rights abuses and exploitation, especially in emergencies. These violations may be identified at the community and/or at the institutional level. Before starting a referral system towards an institution or a service, a WHO quality assessment is strongly recommended. See the manual chapter for a link to the assessment toolkit. IOM MHPSS programs do not promote or refer to institutions or services using inhumane forms of treatment and constriction, such as chaining patients. In practice, IOM also does not refer to health centres that practice electroconvulsive therapy. Issues related to human rights and quality standards should be determined during the assessment and mapping stage. When services or existing resources are not up to standard, IOM could consider a series of capacity building actions. The manual chapter contains links to tools that can support teams to do this.